Dear organizers and colleagues, my name is Martin Burtscher. I am a retired professor from the University of Innsbruck in Austria, where I spent over 30 years researching the effects of hypoxia on the human body. First of all, I would like to thank you very much for inviting me to speak at this great event. Unfortunately, I will not be able to attend in person. Nevertheless, I hope you will find my presentation on the potential use of hypoxic preconditioning interesting and helpful. Hypoxia conditioning is the result of repeated exposure to hypoxia. This is also known as intermittent hypoxia exposure when performed under resting conditions, or intermittent hypoxia training when done during physical activity. Hypoxic conditions can occur naturally at high altitudes, such as in the mountains, or be induced artificially by reducing the partial pressure of oxygen in normobaric environments, such as in tents or rooms, a condition known as normobaric hypoxia. Exposure to intermittent hypoxia, interspersed with normoxic intervals, elicits hypoxia conditioning, which causes resistance to other stresses, such as physical or mental stress. Consequently, exercise tolerance improves, meaning the same exercise feels easier and is accompanied by lower increases in heart rate and blood pressure. The tolerance and effects of intermittent hypoxia exposure depend on the level of hypoxia, the frequency of the hypoxia-normoxia cycles, the total exposure time, and whether the subject is resting or exercising. Very high cycle frequencies, as occur in obstructive sleep apnea, cause negative effects, such as systemic hypertension, whereas lower frequencies, for example, a hypoxia-normoxia cycle duration of 3 to 5 minutes, have been found to be beneficial and are used therapeutically. The here presented data of a review demonstrate that the severity of hypoxia and the frequency of hypoxia-normoxia cycling are crucial parameters that determine the effects of hypoxic interventions. An inspiratory oxygen fraction below 10% at the simulated altitude of over 5,800 meters and a cycling frequency of between 50 and more than 1,000 typically causes negative health effects, as is known to occur in obstructive sleep apnea. By contrast, more mild hypoxia and fewer hypoxia-normoxia cycles may have beneficial effects, such as improved exercise performance and exercise tolerance. Here, the relationship between the inspiratory oxygen fraction and the simulated altitude is demonstrated. For instance, an inspired oxygen fraction of 10% in a normobaric tent is comparable to the oxygen available at an altitude of about 5,800 meters. However, exposure to real altitude always means also dry and cold air and high levels of solar radiation, which is not the case in hypoxic tents or rooms. This slide looks a bit complicated, but it simply shows that hypoxia exposure triggers systemic and cellular responses. These responses help explain why hypoxia can induce beneficial conditioning effects. Systemic responses primarily include hyperventilation and hemoconcentration to immediately counteract the lack of oxygen. The molecular responses are slower to become effective and include, in particular, two signaling pathways associated with the transcription factors, hypoxia-inducible factor and nuclear factor erythroid-2 related factor 2. While hypoxia-inducible factors upregulate gene expression to counteract hypoxemia, the NRF2 pathway counteracts oxidative stress. The following are three examples from our studies investigating the effects of hypoxic conditioning in elderly people. In the first example, we conducted a 3-week intermittent hypoxic program with a group of elderly people, some of whom had previously had a heart attack. There were a total of 15 sessions. For the hypoxia group, each session consisted of 3 to 5 hypoxic periods with 14 to 10% oxygen, lasting 3 to 5 minutes, with 3-minute normoxic intervals. The control group inhaled only normoxic air in the same way. We observed improved exercise tolerance in the hypoxia group, as indicated by lower heart rates, blood pressure, and blood lactate values during submaximal exercise compared to baseline and to the control group. This slide demonstrates that we found very similar results with the same intervention in patients suffering from chronic obstructive pulmonary disease. What is remarkable, however, is that during submaximal exercise, as is common in everyday life, ventilatory efficiency was improved, indicated by lower needs of minute ventilation for the same volume of carbon dioxide exhaled. In the third example, we also saw similar results after a 5 to 7 week multimodal training program, including hypoxia conditioning in some very elderly individuals. Here we used a newer method in which the normoxic phases during hypoxia conditioning were replaced with hyperoxic phases. This could potentially be even more effective than previously used programs. Encouragingly, we also found a correlation, as shown here in the figure, between improvement in the 6-minute walking test and cognitive performance in the individuals of the hypoxia conditioning group. This figure illustrates physiological mechanisms responsible for the improvement of exercise tolerance through hypoxia conditioning. These mechanisms involve the oxygen delivery to the muscles and the oxygen utilization of the mitochondria in the working muscles. Hypoxia exposure at rest and during physical exercise is likely to influence these aspects differently. While repeated resting hypoxia exposures may have a particularly positive effect on the oxygen supply, exercising in hypoxia also seems to promote muscle oxygen utilization. In a recent article, we highlight potential benefits from combining exercise and hypoxia. As discussed before, systemic changes and muscular adaptations will take place. What is less well studied are possible neuropsychological effects that contribute to improved exercise tolerance. In addition to a reduction in cardiorespiratory responses, hypoxia conditioning with exercise may also contribute to reduced perception of exercise stress. This means that activities such as walking, climbing stairs, cycling, and doing manual work are perceived as less tiring and fatigue sets in later. However, exact mechanisms involved and the individually optimized design of exercise and hypoxia are still vague and require future investigations. What is certain, however, is that both exercise and hypoxia conditioning are promising tools for aging in a healthier and fitter way. And finally, the take-home message. Hypoxia conditioning by intermittent hypoxia exposure during resting conditions is more appropriate for sedentary and elderly people or those suffering from chronic diseases. Intermittent hypoxia training combined with physical activity, on the other hand, is more appropriate for younger trained individuals. Intermittent hypoxia exposure is ideal for those who are new to exercise and or have low exercise tolerance. This can be followed by exercise training in normoxia and finally by intermittent hypoxia training. Thank you very much and greetings from Austria.